Hello, Dr. William Berger here, owner and founder of Northeast Medical Practice. We are a concierge-style internal medicine, weight management, and aesthetics practice located in Great Neck, New York on Long Island. And today I wanted to take a moment to talk just very briefly about hormone replacement therapy for perimenopausal or postmenopausal women. There's been a lot of controversy over this topic over the years, and particularly with regard to the Women's Health Initiative study done a number of years ago, which the results of which really kind of through a combination of perhaps misinterpretation as well as the media latching onto it inappropriately overblew the risks of hormone replacement therapy, in particular with regard to breast cancer. But now that we have had time to really look at the data differently and do many, many more studies since, it is now quite clear, although it is always an individual conversation between physician and patient regarding any potential risk, that hormone replacement therapy is the best treatment and is FDA approved for the symptomatic vasomotor symptoms that we call them. These are the hot flashes, night sweats, insomnia, mood changes that can go with the decrease in estrogen as menopause approaches and after it occurs, and also to prevent a fracture in those at risk for osteoporosis. So osteoporosis prevention, not treatment, but prevention. And this isn't to say that there aren't multiple other benefits that most women experience when on hormone replacement therapy, but those are the two FDA-approved indications. Of course, we very often use medicines for off-label, as we call it, for indications or for things that are not the FDA-approved medication. And it doesn't mean we can't do that and that it's not appropriate. So just to be clear about that, because cardiovascular disease risk increases in menopause. And of course, you also have the genitourinary kind of syndrome that goes with menopause for many women. So this is the vaginal dryness, the pain with intercourse called dyspareunia, itching, irritation, recurrent urinary tract infection. The systemic hormone replacement therapy, which these days is often done with a transdermal patch, but can still be done orally. And of course, if you do have a uterus, in order to protect the uterine lining and decrease risk of any kind of uterine cancer, you must always take a progesterone or a progestogen when you're taking estrogen, and that's typically an oral medicine. But the systemic treatment, either oral or patch-based estrogen and progesterone, can help with those bothersome genitourinary symptoms. But also, if patient is not a candidate for the systemic hormone replacement therapy, vaginal estrogen, which is just applied topically, can very well control those kinds of symptoms just in that particular location, and they're also not really absorbed to any significant extent systemically if it's just vaginal estrogen cream, for example. But of course, like I said, it's really a conversation that needs to be held with the patient on an individual basis to go over risks and benefits. But I can say that transdermal estrogen in general has decreased risk for, let's say, blood clot, for example, although the risk is very, very low with the oral estrogens that we use these days. A different oral estrogen formulation was used in the WHI study. So basically, if there are concerns, often using a transdermal route instead of oral or using lower doses can also decrease risk for certain things. So long story short, for women who are within 10 years of menopause or under the age of 60, starting hormone replacement therapy in general, unless there are true contraindications, the benefits outweigh any of the costs or risks. For women who are more than 10 years since the onset of menopause or over the age of 60, to initiate hormone replacement therapy at that time, may be the costs are beginning to outweigh the benefits. However, that's always an individual conversation. And if you've been started on HRT within the 10-year time frame from menopause or under the age of 60, whether or not to continue it beyond that age is also an individualized discussion to be had. It isn't necessarily that we need to stop estrogen or estrogen progesterone therapy at the age of 60. That's not the case. Again, you should be picking up from what I'm saying here is that the pendulum has swung in the opposite direction due to new data as well as reinterpretation of older data for the use of hormone replacement therapy in women who really are having a hard time in this period of their lives, and can very much improve the quality of life and probably improve their overall health too. Because if you remember, I'm always talking about the importance of sleep, for example, and having your sleep constantly disturbed by anything sets you up for metabolic problems, including blood sugar issues, inflammation, and difficulty losing weight, and so on. So whatever we can do to basically improve the lives of women during this period of time is probably going to improve their overall health too. So please remember that everything that I share in these videos is for educational purposes only. No doctor-patient relationship has been formed, and if you have specific questions or concerns about your health, please do not hesitate to reach out to your clinical professionals. But if you would like to learn more about our practice, you can contact the office, 516-604-3418. Find us online at northeastmedicalpractice.com, through all of our social media platforms, including our YouTube channel, and also through our podcast, Longevity MD, on Spotify. Until we see each other again, be in good health.